What's up everybody, my name is Max Feinstein and I'm an anesthesia resident at the Mount Sinai Hospital in New York City. In this video, I'm going to be giving you a detailed look into the first 12 weeks of residency in anesthesiology, ranging from my scariest experiences to the types of procedures I've done and how many hours I've worked and a whole lot more information. If you find this video interesting or helpful, I'd really appreciate it if you liked it and subscribed to the channel. Let's dive in. In general terms, probably the biggest change that's happened over the course of the last 12 weeks is that I've gotten a lot more autonomy and independence in the operating room. So at the beginning, for the first couple of weeks, I had an attending physician who was with me pretty much every second of every case, which meant that I had somebody who was looking over my shoulder, making sure that I wasn't making any mistakes and teaching me along the way. Then slowly during the third week and the fourth week, my attending would step out for a minute first and just be right outside the operating room and sort of peer in. And then, a few days later, maybe he would take some time and go get some coffee while I was in the middle of the case so that I'd have the experience of being alone for a little bit. And then by my fifth and sixth week, I was spending a lot of time in the operating room by myself where my attending would be gone for 10 minutes at a time, 15 minutes at a time. And then by weeks 7 and 8, I'm pretty much in the operating room by myself except for the beginning and the end of the case. One of the major benefits of having this controlled, increasing amount of alone time in the operating room as I gain experience is that I'm able to spend more time diagnosing problems that come up during a case before I get to the point where I need to call my attending physician. Now let me tell you, at the beginning of residency, when I was alone for just a few minutes, if anything at all happened that was slightly concerning, you better believe that I would get my attending in the room right away. Hi, Mr. Patient, welcome to the operating room. You can go ahead and have a seat on the operating table and I'm gonna go ahead and connect all my monitors to you before we get started. Oh, okay, thanks Dr. Feinstein. I'll go ahead and have a... Oh my God! Code Blue and GP17, we've got an unstable airway, get someone in here now! But as the weeks have gone on and I've gained more experience alone in the operating room, I feel more comfortable spending time diagnosing problems, making changes to ventilator settings, pushing some medications in order to address issues that come up intraoperatively before I call my attending and have them come to the operating room to help me out. I should point out that for how much I do feel like I'm alone, I'm not actually alone because it's often the case that my attending's either literally watching me through a video camera that's pointed right at me and the patient, or more commonly, they're watching what's going on through our electronic health records, which has live updates of the medications that I'm giving, patients' vital signs, everything that's going on in the surgery. So even though I'm by myself physically in the operating room, the attending always knows what's going on in the surgery, and so they're keeping a close eye on things even though they're not actually there. For this video, I wanted to get into the nitty-gritty details of all of what I've been doing over the past 12 weeks. So I crunched a lot of numbers before I sat down to record this. I'm gonna be telling you about the number of cases I've done, the number of procedures I've done and what types, number of intubations, how sick my patients are, how many emergency cases I've done, and the number of hours per week I work on average. Now, you might think that I'm neurotic for keeping track of all of this information, but the truth is that I just need to record and report all this information so that I make sure that I've met my requirements to graduate from residency. But I am also slightly neurotic, which lends itself well to being an anesthesia resident. Okay, so the number of cases that I've done over the past 12 weeks is 184, which means that on average I'm doing about 15 cases a week. And keep in mind that cases can vary in length anywhere from 15 minutes to 15 hours and everything in between. Next up is procedures, and this is one of my favorite things about anesthesiology because it means that I have the opportunity to work with my hands a lot. And so I keep track of all of the procedures I do except for placing IVs, which I'm doing anywhere between 5 and 15 times a day. So the first procedure that I've done a lot of are nerve blocks. And so that could be pretty much anywhere on the body that a surgeon's operating. If you can think about a place that has pain, there's probably a way to do a nerve block on it. The ones that I've done most commonly are for abdominal surgery, but I've also done some nerve blocks for upper and lower extremities and also shoulders and parts of the neck. The next procedure that I actually haven't done very much of is spinal anesthesia, which I've only done 2 up to this point. But that's something that I'm gonna have a lot more experience doing once I get onto my OB-GYN rotation, where I'm just going to be doing spinals all the time. But for right now, I've just done 2. Next up is arterial line. So I've done 12 of these so far, and an arterial line is a special type of IV that instead of going into a vein, goes into an artery, which among other things allows me to keep track of a patient's blood pressure on a second-by-second basis, so I don't have to wait for a blood pressure cuff to cycle every 3 minutes, 4 minutes. And then the last procedure that I've had an opportunity to do was a central line, which I've only done one up to this point, but I'm going to have a lot more in my future as I start working with sicker patients and I go into surgeries that require central lines more often. That's generally going to be cardiac surgery, other types of surgeries as well. But as I get into different rotations later this year, I'll have a lot more opportunities to do central lines and other types of procedures. As far as intubations go, I've intubated exactly 80 patients over the last 12 weeks. And keep in mind that a lot of the types of surgeries that I'm doing don't necessarily require that a patient is intubated. There are a lot of other ways to manage a patient's airway while they're under anesthesia for surgery. The next piece of information that I think you'll find interesting is how sick my patients have been. And there are a lot of different ways to determine how sick somebody is. And for the purposes of providing anesthesia for surgery, one of the most commonly used methods is to use the American Society of Anesthesiologists score, which goes from 1 to 6. And without getting into too much detail, the healthiest patient that you can have is an ASA 1, and somebody who is literally brain dead and is going into surgery to have their organs removed for donation is an ASA 6. And so then it's a continuum between 1 and 6. And so very much by design, at the beginning of residency, I'm working with patients who are on the healthier side, and then as I gain more knowledge and experience, I'll move towards working patients who are much sicker. So it's not going to be a surprise that these numbers that I'm going to read right now are mostly on the healthy side. So the number of ASA 1s that I've had, so that's going to be the healthiest person imaginable, is 26. And so these are people who are coming in for elective surgery, maybe something cosmetic, and overall they're very healthy. In terms of ASA 2, I've had 112 patients, so that makes up the majority of the patients that I've done. So they're a little sick, but not too terribly ill. As far as ASA 3s, I've had 24 of these patients, and so these patients are starting to become sicker, who have chronic medical conditions that affect them on a regular basis. Next up is ASA 4s, so these are people who are pretty sick, who have serious medical conditions, and I've had 12 patients who are ASA 4s. I have had no patients who are ASA 5s, and I've had no patients who are ASA 6s. And like I said, I'm gonna have more of these types of sicker patients as I get further along in residency. Then one of the other components of ASA classification is whether a surgery is emergent or not, and I have done 9 emergency surgeries. The next statistic you might be interested in is number of hours spent working. And so we have to keep track of this because it's important to make sure that we don't go over an average of 80 hours per week. And I'll tell you right now, I'm not anywhere close to that. So on a week-by-week basis, the number of hours that I've worked on average has been 52 hours a week of patient care. So let me just contextualize that a little bit. That means the time that I'm spending with patients, looking after them either in the preoperative area, in the operating room, or in the recovery room, or PACU as we call it. That being said, there's more that I do for work every week in addition to looking after patients in terms of clinical hours. So some of those numbers are the amount of time that I spend studying every week. And this has varied dramatically depending on the week and how many cases I have, but on average, I've gotten in about an hour a day of studying. And so that means reviewing flashcards and reading out of textbooks. So that adds up to about 7 hours a week. Next up is the amount of time that I spend reviewing patients before cases. So it's really important to make sure that I have a very good understanding of what illnesses a patient has, what their past surgical history is, what their past anesthetic history is, so that I can formulate a plan that's going to be safe for them for surgery. So on average, I spend about 30 minutes a day reviewing my patients for the next day and coming up with a plan and then talking with my attending physician about that plan. On average, that ends up being about 3 hours a week. Then there's the amount of time that I spend setting up my operating room at the beginning of the day. And right now that takes about 20 minutes, give or take. And I actually made a video showing how I set up an operating room if you want to check that out. And on average, I'm spending approximately 2 hours a week setting up my operating room. So if you add all that up, right now that ends up being 64 hours a week on average that I'm spending either studying or working. This number is actually a little bit lower than I anticipated, which makes sense because right now we're still dealing with COVID-19 and the operative volume has been relatively smaller over the last 12 weeks because we just haven't had the number of elective surgeries that we had prior to COVID. Right now, our operative volume is pretty similar to what it was prior to the pandemic, but over the course of the last 3 months, our operative volume was somewhere in the neighborhood of 80, 85, 90% of what we were doing prior to COVID. So that's why I worked probably a little bit less than I would under ordinary circumstances. On the topic of procedures, I thought this would be a good opportunity to show off some of the more common equipment that I use to do those procedures. So as far as getting access is concerned, the most common pieces of equipment that I use are going to be catheters, of course. And they range from all different sizes, and I've got sort of both ends of the spectrum here for the most commonly used types of IV catheters. So on the small side, I have a 24 gauge needle, pretty tiny, relatively speaking. And then on the bigger side, this is a 14 gauge needle. And so you can see the size difference here. Typically I'll use a 20 gauge needle or a 22 gauge needle depending on what kind of case it is. But if I anticipate that there's going to be a lot of blood loss and I'm going to need to do a lot of fluid resuscitation, then I'm going to end up inserting one of these 14 gauge catheters or maybe a 16 gauge catheter. As for airway management, I do a lot of direct laryngoscopy, which means I use a device to look inside somebody's mouth at their larynx, and what I'm looking for specifically are vocal cords, which hopefully I'll be able to visualize, and then pass an endotracheal tube through the vocal cords if I need to do an endotracheal tube. And so the most common types of devices that I use to do direct laryngoscopy are, this is a Macintosh 3 blade, and it has a light on the end of it. And this is a Miller 2 blade, which you can see looks a little bit different. I'll hold these up side by side so you can get a sense of the different shapes that they have. And technique is a little bit different for both of these, and sometimes there's an indication for using one over another. So I like to be comfortable with both. And another piece of airway equipment that we commonly use is called a laryngeal mask airway, which essentially just sits inside somebody's mouth on top of their vocal cords. So it's not what we would consider an advanced airway, and by that I mean somebody could still aspirate over it, but this is very convenient for situations where I need the patient to be deeply sedated or even under general anesthesia, but I don't necessarily want to or need to insert an endotracheal tube. Another type of device that I can use for laryngoscopy is a video laryngoscope. So this isn't direct laryngoscopy in the sense that I'm actually seeing vocal cords, but it's indirect laryngoscopy because I'm looking at it through this video screen. So you can see here, this is my blade that I use to do laryngoscopy, and you can see right on the screen exactly what is being seen at the tip of the blade right here. So ideally you want to see vocal cords that show up just like this at the end of the screen. Also included in this video laryngoscopy equipment is this fiber optic bronchoscope, which as you can see is very long. We can use this for either nasal or oral fiber optic intubations, which is where we pass this scope all the way through the vocal cords and down to the end of the trachea where we can see the takeoff for both lungs. So that's called the carina. And this long piece of equipment lets us get all the way down there. And we can do this for patients who are either asleep or awake with a whole bunch of numbing medication. And I've had the opportunity to use this quite a few times at this point. Another piece of equipment that I use very frequently is this ultrasound device, which helps me see all different types of structures underneath the skin, blood vessels, arteries, veins, nerves, bones, you name it. It's pretty easy to see on ultrasound. And so I've actually gone ahead and queued this up so you can see what my neck looks like, for example, under ultrasound. So let me see here. So this is what muscle looks like. This is what a bounding artery looks like. And this compressible structure is definitely a vein. So this is an extremely useful piece of equipment for doing nerve blocks and also for gaining IV access in people who have difficult arteries or veins to find. One of the ways that anesthesiology is sometimes described is that it's 95% boredom and 5% sheer terror. And I don't think this is necessarily an accurate way of describing things. Hopefully you're not terrified of what's going on 5% of the time, but I will admit that there are situations that come up that are really scary. And for me, over the last 3 months, the scariest situation came up towards the end of an elective abdominal surgery, and we were just getting ready to wake the patient up. We were starting to turn off all the anesthesia, and all of a sudden I noticed this sound. It's really the worst kind of sound there is, which is the pulse oximeter dropping. At the same time that the oxygen saturation started to go down, the blood pressure cuff just finished cycling, and the new blood pressure was about half of what it had been 3 minutes prior. So I internally am freaking out because I haven't seen anything like this in real life, but I had actually just finished a whole series of simulated emergencies in the operating room that had been taking place several times a week for the past 2 months. And so I did know how to start moving forward. So the first thing that I did was look at my patient and look at my monitors, and I noticed that she wasn't taking as big a breath as she previously was. And then this bag here, which is part of the anesthesia circuit and is connected to the patient's lungs, ordinarily you should be able to squeeze the bag a certain amount. I noticed that the bag was completely stiff and I was not able to move air in or out of the patient's lungs at all. My next step would have been to call for help, but my help was actually already there. My preceptor was in the room, so shout out to Dr. Sherwin, who was with me when this happened and was able to help me navigate everything. So after that, I went ahead and listened to the patient's lungs, and I didn't hear any breath sounds whatsoever. So we diagnosed this tentatively as bronchospasm. As the name implies, bronchospasm is when the muscles inside of the bronchus, inside of the lungs, squeeze down tight, they spasm, and so it's impossible to move air in or out. And so the first thing that you would do is try and deepen your anesthesia, and another possible thing that you can do is administer albuterol, which we did, but if the patient's not moving air in or out of their lungs, then it's hard to move albuterol into the lungs through the anesthesia circuit. So we did that with little relief. So the next step after that was we quickly drew up epinephrine and then gave epinephrine through the IV. And between that and deepening the anesthesia, eventually the bronchospasm broke and the patient's oxygen saturation went back up and they were starting to take nice deep breaths again, and then we were able to comfortably and safely emerge the patient from anesthesia after we had been sure that they were breathing on their own without any problems. I'll also use this opportunity to mention what the most embarrassing thing for me has been, which is the one time that perhaps I was a bit too generous with the anesthesia that I gave, and it took my patient quite a while, maybe on the spectrum of 25 to 30 minutes after the surgery had finished before they woke up. So you never want to be the reason why an operating room is running behind. And so me just sitting there tapping the patient and asking them if they were awake yet for 25 minutes, not a good look. Another one of the things that I love about anesthesiology is the amount of different types of surgery that I have to be knowledgeable about in order to provide anesthesia for it. And I have gotten to see a lot of different types of surgeries over the last 3 months. So I just wanted to give you an overview of what types of surgeries those have been. That includes neurosurgery, orthopedic surgery, urologic surgery, gynecologic surgery, endoscopy, which is done mostly by gastroenterologists, bronchoscopy, which is done mostly by pulmonologists. I've been in a lot of general surgeries and a lot of abdominal surgeries specifically. Some ENT surgeries, so that's anything that's going to be on the ear, nose, or throat. And I've spent a decent amount of time in vascular surgery rooms as well. What I find so interesting about the diversity of cases that I get to do is that I learn a lot about the procedures that I'm giving anesthesia for. So for example, in neurosurgery, it's really important for a patient to be absolutely still, which means completely paralyzed, because their head is literally in pins so that it doesn't move at all, so that the surgeons who are working in a very small area, when they make an incision and go inside somebody's skull, the patient does not move at all. Because if there's any sort of movement, then you can end up with really serious neurologic damage to a patient that could even result in death. So when I'm providing anesthesia for these surgeries, I need to make sure that my patient is completely paralyzed. And then kind of on the other end of the spectrum is vascular surgery, which depending on the type of case, a patient will often be awake but just mildly sedated, so they may be moving around just a little bit, and the reason why we keep them awake in some surgeries like this is because it's safer for them to stay awake without having an endotracheal tube inserted, because a lot of these patients have chronic medical conditions, cardiac conditions, where it's just better to not subject them to the physiologic stress of being intubated. So we just give them a small amount of medication so that they can be nice and relaxed while they're undergoing their vascular procedure. I also wanted to use this as an opportunity to reflect on what my personal interactions have been like with surgeons. And the reason that I wanted to bring this up is because I think sometimes surgeons get a bad rep for being aggressive or insulting or somehow negative qualities in the operating room. And I have to say that personally, my experience at Mount Sinai has been that the surgeons across the board have been very respectful, enjoyable to work with, and a lot of fun oftentimes. And specifically, one of the things that I found really entertaining is to suss out a surgeon's personality based on the music that they play in the operating room. So there's not always music in the operating room, but when there is, I do feel like it reflects a surgeon's personality if they're the ones who picked the music out. For example, I was in the operating room the other day with a plastic surgeon, and I overheard on their speakers some lyrics about bring a bucket, bring a mop, and I was like, what? There are a couple of orthopedic surgeons who I've spent time with who mostly just listen to raging techno music, which is entertaining. The time that I've spent in gynecologic surgeries, there's been a lot of uplifting pop. And it's not unusual to walk into an operating room and have no music playing whatsoever. So I've actually gotten in the habit recently of bringing along my Bluetooth speaker and putting it up on top of my anesthesia cart and just playing music of my choice. Nobody's said anything to me about my music choice up till this point, so I don't think that it's a problem, and hopefully there aren't any surgeons who are going home and having dinner table conversation with their significant others about the unruly anesthesia resident who is playing reggaeton in the middle of their cases. Well, that wraps up this video. I hope you found it interesting, and I'm just now starting my trauma anesthesia rotation for the next month. So keep your eyes peeled for a video about what it's like to rotate on trauma anesthesiology. Thanks very much for watching, and I'll see you next time.